Assalamu alaikum and good morning. I'm Dr. Apnea, working as a demonstrator.
They did not respond to your salam.
Assalamu alaikum.
Very bad Muslims.
I'm Dr. Apnea, working as a demonstrator in oral and maxillofacial surgery.
And I'm Dr. Rizal Subhani, resident of oral and Multidisciplinary Surgery at Khyber College of Dentistry.
We welcome everyone to today's Grand CPC on topic Multidisciplinary Management of Obstructive Sleep Apnea in Patients Due to Mandibular Deficiency. We would also like to extend our warm and respectful welcome to our esteemed Partner-in-Chief, Professor Dr. Mahmood Aurangzeb and Professor Dr. Syed Nasir Shah.
As we gather here for this meaningful event, it is only fitting that we begin by seeking the blessings of Almighty Allah, the most beneficent, the most merciful.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم يسبح لله ما في السماوات وما في الأرض الملك القدوس العزيز الحكيم هو الذي بعث في الأميين رسولا منهم يتلو عليهم آياته ويزكيهم ويعلمهم الكتاب والحكمة وإن كانوا من قبل لفي ضلال مبين وآخرين منهم لما يلحقوا بهم وهو العزيز الحكيم ذلك فضل الله يؤتيه من يشاء والله ذو الفضل العظيم مثل الذين حملوا التوراة ثم لم يحملوها كمثل الحمار يحمل أسفارا بئس مثل القوم الذين كذبوا بآيات الله والله لا يهدي القوم الظالمين قل يا أيها الذين هادوا إن زعمتم أنكم أولياء لله من دون الناس فتمنوا الموت إن كنتم صادقين ولا يتمنونه أبدا بما قدمت أيديهم والله عليم بالظالمين قل إن الموت الذي تفرون منه فإنه ملاقيكم ثم تردون إلى عالم الغيب والشهادة فينبئكم بما كنتم تعملون يا أيها الذين آمنوا إذا نودي للصلاة من يوم الجمعة فاسعوا إلى ذكر الله وذروا البيع ذلكم خير لكم إن كنتم تعلمون فإذا قضيت الصلاة فانتشروا في الأرض وابتغوا من فضل الله واذكروا الله كثيرا لعلكم تفلحون وإذا رأوا تجارة أو لهوا انفضوا إليها وتركوك قائما قل ما عند الله خير من اللهو ومن التجارة والله خير الرازقين.
Just to let you know, today's CPC will be streamed live on YouTube, so colleagues and viewers outside the hospital can follow along in real time.
So today's theme reflects the evolving understanding that the effective management of obstructive sleep apnea, particularly in patients with mandibular deficiency, requires a collaborative and integrated approach. By bringing together perspectives from multiple disciplines, this program highlights the importance of coordinated care in improving functional outcome as well as the patient's well-being. So to commence today's session, I would like to invite our first speaker, Professor Dr. Bashir Rahman, who is leading the Department of Oral and Maxillofacial Surgery at KCD, a distinguished academician and clinician. I would like to request Dr. Bashir Rahman to take the stage and begin his presentation.
Bismillahirrahmanirrahim. Assalamu alaikum. I am grateful to the Honorable Dean Professor Mahmood Aurangzeb, Dean Khyber Medical College, Associate Dean Research Professor Iqbal Haider, Honorable Dean Khyber College of Dentistry, for giving us this opportunity to collaborate and present our topic at this platform. Today is a special day, and why it is a special day? Because it's the 3rd anniversary of Grand CPC at Khyber Medical College. So on behalf of Khyber College of Dentistry and especially the Department of Oral and Maxillofacial Surgery and Department of Medical Education, I congratulate Professor Mahmood Aurangzeb Saab and Professor Dr. Iqbal Haider on achieving this milestone. This is an excellent forum, and we all are getting benefit from it. Sleep apnea, you know that is a sleep disorder which is characterized by repeated episodes of partial or complete breathing pauses during sleep. But the story doesn't end here. It is a misery for both the patient and for the family. And we as surgeons, as physicians, are equally involved or part of that family. The sleep apnea is characterized by snoring and oxygen desaturation, which lead to morning headaches and poor concentration. Due to sleep fragmentation, there is daytime sleepiness, and the major cause in the tongue is pushed backward, a reduced retroglossal space, airway space. This problem is usually manifested at sleep. The most common cause is condylar hyperplasia, which is caused by condylar fracture in childhood. I'm talking about the maxillofacial perspective. And we receive most of the patient from far-flung areas like Dir, Sawat, and which is neglected. And later on, it leads to TMJ ankylosing and mandibular growth retardation. There are other causes like skeletal class 2 malocclusions, micrognathia, and syndromic craniofacial abnormalities. Why multidisciplinary approach is important? Individually, we are like a drop, but collectively, we are oceans. So best outcome requires team-based approach. OSA is not just a single specialty problem. It involves airway, anatomy, neuromuscular tone, obesity and systemic diseases or systemic health, and sleep physiology. MDT in the management of OSA is a result of mandibular deficiency require the services of oral and maxillofacial surgery, otolaryngology, physicians, pulmonologists, speech therapists even, orthodontists. I would like to talk about the role of a maxillofacial surgeon in the management of OSA as a team member of multidisciplinary team. What we can do mandibular advancement surgery. We can go for dissection osteogenesis. We can also perform genioglossus advancement, hyoid suspension, and the benefits may involve increased airway volume, reduced apnea, hypoxia index, and long-term structural correction. I would like to talk about mandibular dissection osteogenesis, which is more important in the management of mandibular deficiency and resulting OSA. It was 2012 or 2013 when the first dissection osteogenesis case was performed at Khyber Dentistry, and I am thankful to Brigadier Muhammad Nazir Saab, who in collaboration with our team, especially Professor Dr. Muslim Khan, performed the first dissection osteogenesis on mandible. और आज तक तकरीबन over 200 cases of mandibular dissection osteogenesis has been performed at the Department of Oral and Maxillofacial Surgery. And this is considered as a workhorse for the management of OSA. I would like to discuss the procedure of mandibular dissection osteogenesis. What we do osteotomy, then we place a device, and the device is quite expensive for poor patients these days. And I would request my dean, respected Dean Professor Syed Nasir Shah and respected Dean Mahmood Aurangzeb to help us in this regard so that we can provide this device to poor patient in future. There is a latency period of 3 to 7 days where a primary callus is formed and then activation starts. और पेशेंट हमारे साथ तकरीबन 1 महीने से लेकर 1.5 month तक एडमिट रहते हैं वार्ड में। शुरू में हम ये करते थे कि हम पेशेंट को एजुकेट करते थे, बेचते थे घर, वो खुद एक्टिवेशन करते थे, और उसका नुकसान ये होता था कि डिवाइस फेलियर और केयरलेस की गलत डायरेक्शन में मोल्डिंग ये चीज़ें उसमें शामिल थी. Then we decided to keep the patient in our ward. And there is a consolidation phase of 6 to 12 weeks. The advantage of distraction osteogenesis is कि इसके साथ सॉफ्ट टिश्यूज, नर्व्स और ये सारे उसी तरीके से उनकी इलांगेशन हो जाती है और एडेप्टेशन हो जाती है और रिजल्ट्स बड़े अच्छे होते हैं इसके. Vector determination is important and it tells you the direction, the amount of distraction or the advancement of job. Usually it is done by orthodontist or it can be done on model surgery or CT based planning. You can see these various directions of vector. For example, if we need lengthening of mandible only, so we go in the horizontal direction, we place a distractor at along this horizontal H direction. But if we need a vertical limb of it, so what we do, we modify our planning like it is shown in the plate. We get height as well as length of the jaw, but it can be modified according to the need of the patient. Indication for mandibular distraction osteogenesis is basically OSA as well as asymmetries, microgranthia, or with or even without sleep apnea. But in majority of the cases, almost 95% of the cases, there is associated severe sleep apnea. Or if the patient is not suitable for orthodontic surgery or particularly in case. There are limitations and risk as associated with all other surgeries. And of a half centimeter, the airway volume has increased. I would like to show a few surgical cases and share it with you. This is one of our patient Hina. 7 years of age, female patient with severe OSA and mandibular deficiency. The planning was tracheostomy followed by distraction osteogenesis. So tracheostomy was done to achieve surgical airway, and you can see the chin position in this lateral view. और इनके बारे में बात बता दूं कि मेजॉरिटी ऐसे जो पेशेंट हैं इनके पेरेंट्स हमें बताते हैं कि इनको हम 2-2, 3 दिन तक ये यूजुअली रख के दे देते हैं ताकि ये लोग आराम से सो सकें. Distractor, bilateral distractor were applied. ये आप देख सकते हैं कि इसमें एक्टिवेशन के बाद एट एंड ऑफ एक्टिवेशन ये ऑर्थोपेक्टोमोग्राम है पेशेंट का. You can see the post-op results and the chin position in the lateral view. एक बात बहुत इम्पोर्टेंट है और वो ये कि इसमें तकरीबन सारे हमारे जो मैक्सिलोफेशियल के टीएमओज हैं उनको पता है कि 3-4 डेज की एक्टिवेशन के बाद पेशेंट की जो सिम्टम्स है वो कम होना स्टार्ट हो जाते हैं. एंड बाय द एंड ऑफ अ वीक ऑफ एक्टिवेशन ऑलमोस्ट सोने लगते हैं पेशेंट और उनकी हेल्थ भी इम्प्रूव होने लगती है. तो इफ यू कंपेयर द हेल्थ ऑफ पेशेंट इवन एंड द सेल्फ एस्टीम ऑफ दोज पेशेंट्स, तो द रिजल्ट्स आर अमेजिंग. एंड देयर इज अ मेंटरशिप प्रोग्राम एज वेल इन द वार्ड कि ये पेशेंट फिर दूसरे पेशेंट को जो एडमिट होते हैं ऐसे डिफॉर्मिटीज के साथ या ऐसे प्रॉब्लम के साथ उनकी काउंसलिंग भी करते होते हैं. एंड देयर इज अ फैमिली सिचुएशन इन द वार्ड. So you can see the profile. the self-esteem even, and the mid-lateral profile, pre-op and post-op. This is another patient, Bakhtavar, who presented at 8 years of age with severe voicing. Blind nasal intubation was performed, and Alhamdulillah, our team of anesthetists are trained in blind nasal intubations, but we need more, which will be discussed by our anesthetist, Dr. Hassan Shafi. This was our first picture. You can see the asymmetry, the lateral profile with chinless face. This is the surgical picture. Distractors, bilateral distractors were applied. After activation, you can see the lateral profile, completion of distraction osteogenesis, and the lateral view with almost zero OSA. And this is a happy patient sitting with the surgeon. This is a third patient. एक बात मैं बताना भूल गया कि ये जितनी भी पेशेंट्स की पिक्चर्स हम दिखा रहे हैं सबसे हमने परमिशन ली है to use their pictures for educational purposes. ये एक और पेशेंट है, ये तकरीबन 18 साल एज में हमारे साथ आई थी और सेम प्रॉब्लम OSA with facial asymmetry और condylar hyperplasia. Yeah, they can lateral view and the magnitude of airway. Bilateral distractors were applied. This is the immediate post-op picture. Before activation, after activation, you can see the profile. This is the 3 months after the surgical procedure when distractor were removed, and before and after. A happy patient, zero OSA and good profile. And this is the last patient I would like to show. Among those 200 patients we operated in oral and maxillofacial surgery. You can see the asymmetry both in frontal and lateral view. और ये एक यतीम बच्चा है. Among all those patients, this is very special because इस पेशेंट ने मुझे 2-3 दफा रुलाया और शायद बहुत से और लोगों को भी रुलाया होगा. Used to sit alone in the ward, कोई इसके साथ नहीं होता था और तकरीबन 1.5 month तक ये हमारे साथ वार्ड में बिल्कुल अकेले रहा. सिर्फ लास्ट डे में इनकी मदर पे आई और इनको लेके गया. तो ये इनकी स्टोरी ये थी कि ये स्कूल नहीं जा सकता, ये बाहर नहीं निकल सकता, ये मस्जिद नहीं जा सकता, बिकॉज हमारा मुआशरा कुछ इस तरह डेवलप कर गया कि हम मजाक उड़ाना स्टार्ट हो जाते हैं. तो bilateral distractor were applied, or this is the result after activation and completion of distraction. This is the frontal view, this is the lateral view, and you can see the pre and post of a picture. Maybe in future we perform a genioplasty as well in order to improve his profile more. And this is how we say goodbye to patients on last visits, because patients don't care how much you know until they know how much you care. So the take-home message is mandibular distraction osteogenesis is a life-changing airway enlarging procedure, especially in OSA due to mandibular deficiency, offering both functional airway relief and skeletal correction. I am lucky that I have been surrounded by my family, my patients, my students. Majority of them are sitting here as consultants now, my brothers and friends, my mentors, and my well-wishers.
Thank you, sir, for such an informative presentation. Now we are pleased to invite Dr. Roxana Javed Farooqi, who is Associate Professor in the Department of Pulmonology. Her extensive clinical and academic experience will greatly enrich our understanding of obstructive sleep apnea from pulmonology point of view. Please, ma'am, you are humbly requested to come and begin your presentation.
Alhamdulillah, we have completed 3 decades of grad CPC, and I was one of the presenter in the second CPC and on the same topic, that is obesity hyperventilation syndrome, because that topic was on obesity and bariatric surgery. So I congratulate respected dean and Iqbal Haider Saab and all of us, Alhamdulillah. And Bashir Saab, your strength is shown in the heart, and congratulations in advance. So topic of today is already obstructive sleep apnea, and I'm Dr. Roxana Javed Farooqi. I'm Associate Professor of Pulmonology. They have given me pathophysiology and diagnosis so that we can go ahead with the management with them. So it will include the introduction, classification of OSA, epidemiology, pathophysiology, complication of OSA, diagnostic workup, clinical signs and symptoms, and OSA management, a bit of it. So as already said, obstructive sleep apnea is a sleep disorder. It is characterized by pauses in breathing, that is apnea, and period of shallow breathing, that is hypopnea, during the sleep. This causes loss of for a few seconds to a few minutes, and it happens during the sleep at night. When repeated collapse occurs, it results in changes in ventilation, intermittent hypoxia, arousals, which results in daytime sleepiness and lead to definitely cognitive impairment. So there are 3 types of sleep apnea. One is obstructive sleep apnea, which is because of the external compressions, and that is the central sleep apnea. It is because of the central, the brain is not giving the message to the respiratory muscle to work, and there is a mixed type of it. So there are a few definitions which are like apnea. What is apnea? Cessation of airflow for at least 10 seconds. And hypopnea is reduction of airflow resulting in oxygen desaturation of more than 4%. What is apnea hypopnea index? It is the average frequency of apnea and hypopnea events per hour of the sleep, and it is calculated by the sleep study like it polysomnography. So it is a machine related definition. This is already I discussed. So what is the epidemiology? OSA is a sleep disorder, and it is the 3rd most common cause condition of asthma and COPD. You can imagine how burden disease it is, and it is now emerging because sleep study is more famous in medical field now. It is more prevalent in US, like 2 to 4% of the women and 4 to 9% of the men, and it is increasing in UK as well. And now we will try to have our own data as well, inshallah. So what is the pathophysiology? During sleep, as everybody knows, the muscles get relaxed, including the pharyngeal wall dilator leading to pharyngeal narrowing. So when there is internal obstruction like adenoid, tonsils, and this abnormal airway, there is a collapse of the airway leading to apnea and hypopnea. So what happened during apnea and hypopnea? There is hypercapnia. So the brain detects chemoreceptors that there is hypercapnia and then wake up the patient. So there is a sleep and wake up cycle, and patient got a disturbed sleep. So in the morning he have got excessive daytime sleepiness, and he's got bad moods and effects of OSA. So loss of upper airway muscle tone, increased pharyngeal resistance, negative pharyngeal pressure during inspiration, and upper airway collapse, leading to OSA symptoms. So what is obstructive obesity hyperventilation syndrome? There is obesity, more than BMF 30 kg per meter square, there is hypoventilation, then mean there is hypercapnia of more than 45, and there is sleep distorted breathing. So this is the combination of it. If you see this boy, everybody knows Charles Dickens' fat boy. He is sleep all the day because he has got a disturbed sleep because of OSA. So what is sleep-related disordered continuum? There is snoring, there is upper airway resistance, there is hypopnea, there is apnea, lead to obesity, hypoventilation syndrome. So what are the general risk factors? There is obesity most of the time, not all the time. Male sex is common in that. Positive family history. People are not fat but they have snoring. Postmenopausal state. Congenital fetal like Down syndrome, Perry-Robin syndrome as already discussed, Marfan syndrome, nasal abnormalities, which will be researched by ENT specialists, nasal congestion, nasal polyposis, deviated nasal septum, medical conditions like acromegaly, hypothyroidism, structure of abnormality like large neck, temporomandibular joint abnormalities, macroganthia, macroglossia, rectal abnormalities, and tonsillar hypertension. So what complication can occur with OSA? When there is daytime drowsiness, there is hypertension, there is heart attack, stroke, memory loss, diabetes, depression, insomnia because sleep is disturbed, and they can have early death because of arrhythmias. So how do you diagnose? We will diagnose by the history. The common history is snoring, which I already said they have snoring, they have daytime symptoms, they have nighttime symptoms, and how we do the clinical evaluation, there are many scores, but the common is ESS score and STOPAC. Investigation is the polysomnogram, that is sleep study, is the gold standard. Encephalometric X-rays, which already discussed, CT scan, MRIs, and fiber optic nasopharyngeal, that were discussed by Dr. Aftabi. So the symptoms. When there are daytime symptoms, there will be nighttime symptoms. So there is a circle. Early morning headaches, daytime sleepiness, poor concentration, irritability, falling asleep during routine works. So there will be, in the night they have persisting snoring, they have witnessed pauses by the family member, choking, gasping, restless sleep, and frequent visits to the bathroom because of the disturbed sleep. So the main symptom is excessive daytime sleepiness. One of the most common causes which affect their quality of life, impair daily performance, and causes neurocognitive deficits. This is assessed by a score which is known as Apnea Sleepiness Score, which actually is a questionnaire which is used to help determine how frequently a person can doze. So there are these 8, like sitting and reading, they are dozing, watching TV, sitting in a public place, as a passenger in a car they sleep, lying down in any afternoon they get sleep, sitting and talking to somebody they get sleep, sitting and watching TV and they can have this. So the score is when it is from 0 to 9, but between 11 to 15 they have got mild to moderate disease. If it's more than 16, then severe disease. So we do the ESS we'll see the progress of the treatment as well. The other is the stop band, which is mostly applied by the anesthesia people. It includes snoring, tiredness, observed apnea, pressure, hypertension, BMI more than 35, age is over 50, neck circumference more than 40 centimeters, and gender mostly in the male. So when it is more than 3 points, then it has got high risk of obstructive sleep apnea, and when it is less than 3, then it's low risk. So what is the gold standard to diagnose obstructive sleep apnea? It's the polysomnography of sleep study. So there are 4 levels. The level 1 is in labs sleep study. We have 15 to 20 sensors, and it is the gold standard nowadays. Level 2 is it can be done in the hospital and the home. The sensors are less. And level 4 has got only overnight pulse oximetry, which can done in the home. So this is the polysomnography level 1. We have EEGs, electrocardiogram, electromyogram, oronasal airflow, chest wall effort, snore microphone, and oxygen saturation monitors. Alhamdulillah, this is the KTH pulmonology sleep lab. We have level 1. Alhamdulillah, we have done And last year, more than 86 cases of sleep studies, and Alhamdulillah, we have published 3 papers and 4 papers in the pipeline, and it's just want to tell that we have this facility. You can send the patient. This is the obstructive apnea in obstructive type. You can see that this line shows that there is a hyposaturation, but respiratory effort is there. This is the obstructive type, and this is the central type. There is no hypoxia, and there is no respiratory effort. that is detected by the OSA sleep study. So how we grade? It is grade on apnea-hypopnea index. If it is less than 5, it is normal. We often snore at night. Mild is 5 to 15, moderate is 15 to 30, and more than 30 is severe form. So what is the management? This is the general management because I can't cover it fully. So pharmacological and non-pharmacological. In pharmacological, there is devices like PAPs, continuous positive air pressures, bi-level, that is biventricular, bi-level positive air pressures, nasal CPAPs, oral appliances that already sir discussed, surgeries like tracheostomy, TPO that was discussed by NT people. Non-pharmacological is very important. Lifestyle changes. Nowadays it is very important to have exercise, take care of obesity, diet, and the first CPC of mine was bariatric surgery. It is, alhamdulillah, they have done a lot of cases on it. Then positional therapies, educational and behavioral therapies. Nasal CPAP is a very promising treatment for ASA. It increases the caliber of airway in the retropalatal and retrogalsic region. It increases the lateral dimension of upper airway, so the patient can have it and have a sound sleep with that. Other modality, which already BiPAP therapy, it is important in OHS, that is obesity hypoventilation syndrome. Oral appliances, sir, I have already discussed. Surgical correction of the upper airway will be discussed by ENT people, and bariatric surgery. I was also given a bit of pre-operative screening for OSA. The first is the detailed history, OSA pre-operative screening by the Stop Bank Berlin questionnaire. So on that, if it is less than, like in Stop Bank, less than 3, then have low risk. So go ahead with the surgery. If they have more than high risk, so you have to give up detailed sleep study, and then they may need a CPAP or BiPAP before and after surgery, and then we have to optimize the treatment accordingly. So conclusion is that when obstructive apnea is a complete complex disease, it requires a multidisciplinary approach. And polysomnography is the gold standard to diagnose a OSA. And health education regarding snoring, obesity, lifestyle changes is the need of the day. And timely refer to the surgical people like Maxillofacial and ENT people, and bariatric surgery is the required. This is my references, and thank you is the best prayer that anyone can say. Thank you.
Thank you, ma'am, for such a wonderful presentation. Now it's time for the anesthesia department to step in and take the lead. Dr. Hassan Shafi, Assistant Professor Anesthesia in the Department of Oral and Maxillofacial Surgery, Harvard College of Dentistry, will be addressing the topic of obstructive sleep apnea from the lens of anesthetist, offering valuable clinical insights from the anesthesiology perspective.
Dr. Hassan Shafi, and I'm working as Assistant Professor of Anesthesiology in the Department of Oral and Maxillofacial Surgery. So we got a lot of insight from Dr. Rossana and Dr. Bashir about what OSA is due to mandibular deficiency, and I'm going to tell you that how anesthesiologists help in this regard. So what is OSA? As everyone has discussed, that it is recurrent collapse of pharyngeal airway during sleep, resulting in reduced hypopnea or complete cessation of airflow despite breathing efforts. Here you can see a picture where normal breathing during sleep is occurring. In the next picture you can see that the tongue is very big and not very toned. and the soft palate is long and flabby, as a result of which airway is blocked and obstructive sleep apnea occurs or there is no flow of air. Now, what happens, as ma'am has already discussed, that patient experiences arterial hypoxemia, hypercarbia, polycythemia, systemic hypertension, pulmonary hypertension. There may be cardiac rhythm disturbances, right ventricular failure, heart diseases, and cerebrovascular events. Dr. Osana has discussed this in detail, that what happens in obstructive sleep apnea is that the patient experiences hypoxia and hypercapnia, as a result of which there is increased breathing effort. So patient wakes up and upper airway reopens. Breathing is restored, oxygen levels go up, carbon dioxide levels go down, sleep is restored. But upper airway dilator muscle activity is reduced and upper airway collapse. This is how the cycle of obstructive sleep apnea continues. Now, what are the risks associated with anesthesia? We have to be very careful in perioperative and post-operative period because of the morbidity and mortality associated with it. The more severe the OSA, the more perioperative complications, which can be potential loss of airway, difficult intubation, and respiratory depression, airway obstruction, and delayed recovery in these patients. In our setup, when we see patients with OSA with mandibular deficiency, we have two types of patients. Patients who have TMJ ankylosis and patients who do not have TMJ ankylosis. Here you can see a picture of this patient. This is a child. He has a deficient mandible. He had TMJ ankylosis and limited mouth opening. You can see radiographs where you can see that the airway is completely blocked. Now, there are some patients who do not have TMJ ankylosis and they have good mouth opening. So, easy access to the airway. Usually patients have narrow airway and फिर काफी problems होती हैं उनको intubate करने में. So pre-operative diagnostic workup. Again इसमें जो है history बहुत important है. इसके questions होते हैं, patient से पूछने होते हैं, जो कि उनके stop back analysis है. मैंने इसके बारे में काफी डिटेल में डिस्कशन की. मैं भी आगे उसका बताता हूँ. लेकिन हम हिस्ट्री में उनसे बेसिकली कि do they snore, daytime sleepiness or tiredness or exhausted, फील करते हैं, किसी और ने उनको ऑब्जर्व किया है, मेडिकल रिकॉर्ड्स की कोई प्रीवियस मेडिकल हिस्ट्री ऐसी हो, पॉलीसोनोग्राफी डॉक्टर साना हैज ऑलरेडी डिस्कस्ड इन डिटेल. लेकिन इसका जो हमें रिजल्ट मिलता है इन द एंड में एपनिया हाइपोपनिया इंडेक्स. सो नॉर्मल रेंजेस और माइल्ड स्लीप एपनिया तो AHI 5 to 15 है, इट्स कंसिडर्ड माइल्ड. Moderate sleep apnea and severe sleep apnea, जहाँ पे AHI is more than 15 to 30 or AHI more than 30. So this shows that patient will have a difficult airway or intubation जो होगी वो काफी difficult होगी. Preoperative screening workup में apart from BLIs, we do the stop bang analysis, we do McNamara airway analysis, we do chest X-rays, हम देख लेते हैं कोई पैथोलॉजी वगैरह या कोई और चेस्ट इन्फेक्शन तो ऐसी प्रॉब्लम तो नहीं है. ECG एंड इको कर लेते हैं क्योंकि कुछ पेशेंट होते हैं दे आर सिम्प्टोमिक एंड दे माइट हैव एनी वैल्वुलर और अदर प्रॉब्लम्स टू रूल आउट देम एंड डील विद देम ड्यूरिंग द पेरीऑपरेटिव पीरियड. ओके, मैकनमारा एनालिसिस हम करते हैं जिसमें कि हम अपर एयरवे में देखते हैं कि सॉफ्ट पैलेट और पोस्टीरियर फेरेंजियल वॉल का डिस्टेंस कितना है. इफ इट इज between 15 to 20 millimeters, that's normal. Lower airway में हम देखते हैं कि mandibular और tongue का distance to posterior pharyngeal wall कितना है. It must be between 11 to 50 millimeters. If it is less than 7, then surgical intervention will be needed. Stop bang analysis. You ask the patient about do they snore, are they tired in the morning or sleepy in the morning. किसी और ने उनको ऑब्जर्व किया है स्लीप एपनिया के चोकिंग के एपिसोड्स नहीं हुए. They have high BP, BMI more than 35 kg, per meter square age more than 50 as the age advances, तो sleep apnea के chances increase हो जाते हैं. Neck circumference more than 40 centimeters and males में इसकी ज़्यादा propensity होती है. 0 to 2 scoring 1 for each answer scoring interpretation. 0 to 2 low risk, intermediate risk is 3 or 4, more than 5 is high risk. And उसमें फिर मैंने जैसे बताया कि और modalities को इस्तेमाल किया जाता है and later on surgery की तरफ जाया जाता है. So when the patient comes to us, we look at them externally for any markers of difficult intubation. Body habitus कैसी है, head and neck anatomy कैसी है, short neck तो नहीं है, small mouth, limited mouth opening, teeth protruded हैं, any other malocclusion. Evaluate करते हैं from 3-3-2 rule. If the patient can put 3 fingers between their incisors, so they have good mouth opening. If not, then they have limited mouth opening. Is the mandible length 3 fingers from the mandible to the hyoid bone? If it's that way, that's normal. If less than that, then it will be difficult airway. Distance from the hyoid to the thyroid is 2 fingers. That's what we are looking for. Melanopathy class 1-2 तो नॉर्मल्स में आ जाता है. 3-4 अगर होगा तो डिफिकल्ट इंट्यूबेशन हो जाएगी. कोई ऑब्स्ट्रक्शन हो, any neck hematoma, any cancers, angina, any other problem, तो larynx और या obesity है तो laryngoscopy जो होगी वो प्रॉब्लम होगी. Neck mobility अगर if it's good तो you can intubate the patient easily, but patients जिनको arthritis हो या trauma हुआ हो or wearing a cervical collar, तो there will be difficult intubation because neck mobility नहीं हो सकेगी. Neck will be stiff and can't move. In top management में we have to be careful with the sedatives, especially because sometimes we give sedatives to patients to relieve their plea of anxiety. So in these cases we avoid them. At the time of intubation we have to be well prepared because intubation is often difficult in these patients. At the time of extubation we have to examine them, we have to check their stats, their BP, their pulse, and everything is monitored carefully. If there is concept, then we go for extubation. We avoid nitrous oxide in these patients because nitrous oxide causes airway inflammation. We monitor for any hemodynamic changes. If we see patient is fit, he has recovered well, he is breathing spontaneously, and he or she are maintaining their stats, pulse, BP are normal, we shift them to the ward. Otherwise, we plan to shift them to the ICU. Judicious fluid management is essential to avoid CCF. Pre-medications में, as I told you, benzodiazepines को avoid करते हैं because upper airway musculature को relax कर देते हैं, as a result of which the pharyngeal space is reduced. So we usually avoid them. Ideally, inhalational induction would be better. It would be better to use that instead of IV injection for these patients. Choice of anesthetic technique. It's better that general anesthesia with a secured airway is preferred over a deep sedation without a secured airway. We have to be cautious with the following drugs that we use, जो हम usually use करते हैं anesthesia में, जैसे propofol हो गया, thiophantal हो गया, opioid analgesics हो गए, neuromuscular blockers and nitrous oxide. Intubation technique mostly जो हम अपने setup में use कर रहे हैं, that is blind nasal intubation because we don't have fiber optic or video laryngoscope, and I discussed this matter with our chairperson and dean, and they have ensured that very soon we are going to acquire these. तो blind nasal intubation usually की जाती है और हम इसमें काफ़ी अब एक्सपर्ट भी हो गए हैं and we do it successfully. Patient intubate भी हो जाते हैं, but if that fails, we go for tracheostomy. We have already counseled the patient कि अगर ये fail होगी, then we will be sent to ENT department. ENT department has been very cooperative in this regard, and tracheostomy भी वो कर लेते हैं, उसकी वो care में भी हमारी help करते हैं throughout. Now during the laryngoscopy, as you can see, grade 1 and grade 2, that's easy. Trachea is visible, intubation can be done, but if it's grade 3 and 4, then you have to be ready with all the essential equipment required for the difficult airway, adequately to oxygenate the patient, And if you have a fiber optic, go for it. Otherwise, you have other option as blind nasal intubation. But if it fails, then go towards the tracheostomy. OSA के जो patients होते हैं उनकी increased sensitivity होती है to opioids. Analgesia, good analgesia anesthesia की basic requirement है. लेकिन opioids जो हैं ये delayed recovery और post respiratory depression cause कर सकते हैं. So you have to be careful while using them. Titrate करके दें, dose उसके मुताबिक दें या फिर go for NSAIDs. At the time of extubation, we see if the patient is conscious, communicative, breathing spontaneously with adequate tidal volume and retaining their oxygen saturation. So we extubate these patients and put them in semi-upright or lateral position or the recovery position after they have recovered from neurovascular blockade. We see if उनके जो वाइटल्स मॉनिटर कर रहे होते हैं उसमें बीपी अगर कोई इशू है तो एंटीहाइपरटेंसिव्स का यूज भी किया जा सकता है. पोस्ट ऑपरेटिव मैनेजमेंट में रेस्पिरेटरी डिप्रेशन एंड रेपिटेटिव एपनिया कॉमन है आफ्टर एक्सट्यूबेशन. सो केयरफुल मॉनिटरिंग इन द पोस्ट एनेस्थीसिया रिकवरी रूम्स में उनको काफ़ी केयरफुल कार्डियोरेस्पिरेटरी मॉनिटरिंग की ज़रूरत होती है. ऑक्सीजन सप्लीमेंटेशन इज इम्पॉर्टेंट. ये डिपेंडेंट हाइपोक्सिक रेस्पिरेटरी ड्राइव को तो प्रिवेंट नहीं करेगा बट ड्यूरेशन ऑफ एपनिया को जो है वो सिग्निफिकेंटली रिड्यूस कर देगा. और एएसए के मुताबिक इन पेशेंट्स की जो रिकमेंडेड टाइम ऑफ ऑब्जर्वेशन को रखा जाता है ऑब्जर्वेशन के लिए इज ऑलमोस्ट 3 hours मोर देन पेशेंट्स हु डोंट हैव ओएसए. वी सी पेशेंट हैज रिकवर्ड वेल एंड तो फिर हम उसको शिफ्ट कर लेंगे वार्ड में या प्राइवेट रूम में wherever they are admitted. If not, if they are not maintaining their vitals, their sats are going down, they are not responsive, then we arrange for ICU. Adequate pain relief, जैसे मैंने पहले कह दिया, but it would be better to use non-opioid analgesics in these patients. I went through a comparative study which was conducted in India, जहाँ पे inhalation induction was preferred and muscle relaxants were avoided in OSA patients. Out of 20 patients, 10 patients were intubated by fiber optic, 6 went through blind nasal intubation, 3 had video laryngoscopy, and 1 patient underwent elective tracheostomy. Mask ventilation in OSA patients was difficult. At extubation in OSA patient, a more difficult airway maneuver is needed. According to our data and observation, what we have seen in patients present to us in KCD, majority of patients with OSA have TMJ and cardiolosis. Such patients are extremely malnourished with low BMI. These patients take longer to recover from anesthesia after surgery. Hence, more careful monitoring is required in these patients. Here's a picture of this patient who presented to us. As you can see, he has you can see in this patient that he has a deficient mandible, he has limited mouth opening, and he had prominent incisors. He also had OSA. We faced a lot of problems while intubating him because it was difficult intubation, but we finally did it. Surgery went on without any event, but at recovery he was not recovering, and we kept him for almost 2 to 3 hours, and fortunately he recovered. And you can see here the after result of DO that was placed. Dr. Bashir had already shown this picture to you. इसके लेटरल सबक्यूपर उन्होंने इनकी मेजरमेंट्स ली। इसका पहले एयरवे कैसा था और बाद में कैसा था, ऑलमोस्ट मेरा ख्याल है कि 15 मिलीमीटर्स इसके एयरवे इम्प्रूव हुआ, इसके सिम्टम्स भी जो है वो इम्प्रूव हुए। So take home messages in patients with mandibular deficiency, obstructive sleep apnea represents a convergence of anatomical and physiological risk that mandate anticipatory airway management and cautious anesthetic strategy. Thank you.
Thank you, Dr. Hassan, for a beautiful presentation. Now, I'd like to invite our last speaker, Dr. Aftab Ahmed, Associate Professor, Otolaryngology Department at Khyber Teaching Hospital. Through his work and experience, Dr. Aftab has been closely associated with obstructive sleep apnea. We are grateful to have the opportunity to benefit from his perspective and insight. So please, I would request you to come and proceed with your presentation.
Bismillahirrahmanirrahim. I'm Dr. Aftab, consultant ENT, Khyber Medical College, Khyber Teaching Hospital. And today I will talk on the ENT perspective in the multidisciplinary management of the obstructive sleep apnea. Obstructive sleep apnea can be regarded as a condition characterized by the repetitive upper ear obstruction leading to sleep fragmentation, cardiovascular stimulation, and oxygen desaturation during sleep. These together lead to clinical symptoms such as snoring, unefficient sleep, excessive daytime sleepiness, and an increased risk of cardiovascular diseases, hypertension, diabetes, and especially the road traffic accidents. Now, these are the terms frequently used in the presentation. Sleep apnea already described as a cessation of the breathing for 10 seconds or more. Apnea is a complete breath hold, while the hypopnea is a partial breath hold. Now, it is very clear that OSA is not because of the anatomical variation. Because some of the OSA patients have normal anatomy, so it means that it can be due to a complex defect in the complex pathway from the central nervous system to the pharynx, which control the dilator muscles of the pharynx. So it is very important that to exclude all the other causes, especially the CNS problems, and also the laxity and flexibility of the pharyngeal muscles, which occurs in the late age, to avoid the unnecessary intervention. Why ENT? ENT is a gateway of the lower respiratory tract, and any obstruction in the nose in the form of BLS, in the polyps, the turbinates hypertrophy, the adenoids, the larynx, etc., will definitely affect the sleep and the snoring. It's not only these matter, but if there is like obstruction of the nose, it will lead to resistance of the upper airway. And second, these patients become the open mouth breathers, and because of this, all the function of the nose, which is filtration, humidification, air condition, is lost, and these mouth breathers lead to dryness of the mouth, trauma to the muscles, further aggravate the symptoms. So OSA is not purely a skeletal problem. Mandibular deficiency causes multi-level airway collapse, and ENT defines the size, severity, and reversibility of the obstruction. Risk factors. Among the risk factors, the obesity on the top. The fat deposition in the neck and the parapharyngeal space narrows the upper airway, and it is estimated that up to 75% of those with a body mass index above 40 kg per meter square have obstructive sleep apnea. Male gender, the prevalence is more in the male than the female because the male have a narrow and longer upper airway. Advanced age, because with the increased age, the laxity, flexibility of the upper airway increases. And the cranial features in abnormality is already discussed with the microplegia, retroplegia, Down syndrome, etc. Large tonsil, adenoids which obstruct the airway, and thick neck, where the circumference increases up to 17 inches, then prevalence increases. Hypothyroid. The physiological changes because of the low thyroxine will lead to fluid retention, macroglossia, weight gain, and secondly, the tumor effect. The pressure effect of the goiter will lead to necrosis and degeneration of the laryngeal framework, which lead to collapse of the upper airway, the lower airway. Clinical presentation. These patients already discussed present with snoring, fatigue, wetness, breath holds, gasping, choking, excessive rate and sleepiness, fragmented sleep and unrefreshing sleep. ये patient fragmented sleep जिस तरह कहते हैं ना पुश्तों में कि चरगा नुखोगी 5 मिनट अदा होगी 5 मिनट वेट। हमारा एक गांव में एक है मुअज्जिन है हमारे मस्जिद का। He is a documented case of OSA. Unfortunately, he is unfit for the surgery because of the cardiac problem. जब वो अजान देते तो अजान और नमाज के बीच में 10-15 मिनट्स का गैप होता है, उसमें वो सोया होता है मस्जिद में। So it's very pathetic. Management includes detailed history, clinical examination, some relevant investigation, and final diagnosis and treatment. History is very important because the history, detailed history, is very important because it will help to identify the site. It will exclude the central sleep apnea from the peripheral sleep apnea and guide to the surgical intervention. So the history department is very important because these are the questions which can be asked from the partner, that how severe is the snoring, is audible outside the room, downstairs or by the next room. Does the patient snore with mouth open? It can be due to pathology in the nose. Snore is positional because if the patient sleep in the supine position, the tongue falls back and obstructs your upper airway. Are there episodes of crescendo, snoring, apnea, choking, gasping? Is the patient restless, and are there any other limb movements to exclude the periodic limb movement disorder? Does the patient sleepwalk or sleep talk, which is the characteristic of the non-REM sleep in which the brain is partially awake? Now from the patient, do you feel that your sleep is refreshing? Do you get morning headaches? Do you feel tired during the daytime? Do you feel that your nose is blocked? Do you smoke and drink? Smoking is irritant to the respiratory mucosa, and alcohol causes relaxation of the muscle during sleep. Do you have any other medical problems such as blood pressure, heart problem, diabetes, thyroid glands, post history of stroke? Have you had any driving accident? It's very important because most of the patients which I have approached were the drivers. ये जो गल्फ कंट्री में चले जाते हैं वहाँ पे ड्राइवर्स होते हैं तो इनकी typical they had a positive accident history. What medication do you take, especially the sleeping pills which causes muscle relaxation during the sleep? Thorough examination, the body height and weight are measured to calculate the body mass index, and those who have 25 greater than 30 considered as obese. Neck collar measurement already discussed, with greater than 17 inches prevalence in cases. On general inspection, to look out for craniofacial or facial skeleton framework deformities such as seen in the patient with acromegaly, maxillary protrusions, and micrognethia. Now, ENT examination to see for DNS, deviated nasal septum, polyps, turbinates, trismus, laxity of the soft palate, palatine tonsils, the length of the uvula, and general crowdness of the oropharynx. Malumpati scoring already discussed. And these patients usually have grade 4, in which we can see only the hard palate. The soft palate and the tonsils cannot be visualized. And then the most important is the flexible fiber optic direct laryngoscope, which we pass through the nose and can see all the pathology in the nose and nasopharynx and hypopharynx. Here you can see the polyps on the interior endoscope. The tonsil we graded according to the Fredman classification, and usually these OSA patients have grade 4 tonsil. Grade 4 means when the tonsil touches each other at the midline. You can see the adenoids. Imaging CT scan, we prefer CT scan only when we are suspecting quinine atresia, which is the gold standard. Otherwise, if you are planning the radical surgery, especially the maxillomandibular advancement procedure, then we go for the CT scan. Otherwise, CT and MRI have a lateral role in ENT. Drug-induced sleep endoscopy is very important because it predicts your surgical outcome. The sedative give is midazolam, propofol, which have rapid action and rapid recovery, and this is done by along with the anesthetist in the operation theater, and with the good cardiopulmonary monitoring, and then we pass the flexible endoscope to identify the exact site of the obstruction. Overnight oximetry is done at the home. The pulse oximeter is applied over the finger, and then it is attached with the wristwatch computer, which record all the activity. And when there is a dip of saturation, 4% is significant. For example, if it goes from 94 to 90%, it's clinically significant. And the exclusion criteria is to exclude all the lower lung diseases. Overnight polysomnography, already discussed in detail, is a gold standard. It is a non-invasive overnight test which record all the parameters of sleep physiology. It helps to diagnose the obstructive sleep apnea and central sleep apnea, differentiate from the central sleep apnea. Narcolepsy. Narcolepsy is a chronic neurological disorder in which affects the sleep-awake cycle, and patients lead to excessive daytime sleeping and sudden attack of sleep, periodic limb movement, and unexplained excessive daytime sleep. Criteria for diagnosis already discussed. Apnea hypopnea index, who has greater apnea and hypopneas per hour, is considered most severe form of obstructive sleep apnea. Now to the treatment. Non-surgical, the most important is dietary modification for weight loss. It is very important, and for those who cannot manage the weight with the diet, they can go for the bariatric surgery. Avoiding alcohol, positional therapy. As I have mentioned, if the patient has a problem with the supine position, then we go for the tennis ball therapy, in which we stitch a tennis ball with the shirt between the interscapular region, and when during the sleep, when the patient go in the supine position with the discomfort, he immediately changes position. Agar sunat ke treatment, CPAP is the gold standard. It was first introduced in the 1981, and since then a lot of modification has been made by the different industries. The mechanism of action is produce a positive pressure which keep pattern the upper airway during the sleep. Nasal surgery and uveoperitocalaringoplasty, UPPP, the most commonly procedure done for the OSA, in which we remove both of the tonsils, stitch the interior posterior pillar, remove the uvula, and partially remove the soft palate. The main aim is to open the upper airway. Laser assisted uveoperitoplasty, radiofrequency, thermal ablation, are these aims to produce scarring, fibrosis, and contracture to pattern the upper airway. Transoral robotic surgery is a new development, and tracheostomy is the last option when the other measure fails or not provided. Now this is the, in the next slide I will discuss a child with obstructive sleep apnea. He presented with the grade 4 tonsils, which we call kissing tonsils. When they touch each other in the midline, and you can see the external lateral view with enlarged adenoid, which almost obliterating the nasopharynx with almost zero air power. Now this is a case. This is a 3 years old child. Start snoring. When you do apnea attack. So this process remains for all of the night. स्कीमा ने कहा कि डॉक्टर साहब मेरी ज़िंदगी जो है अज़ाब बन गई है, रोज़ आ रहे हैं, मैं सारी रात इसके साथ जागती रहती हूँ, और then I cannot be able to do my domestic work.
Daytime sleepiness for her mother.
This is a 3 days old baby with the bilateral bony choanal atresia. These children are unable to feed because they are obligate nasal breathers with obstruction very pathetic.
What do you do for them then, Dr. Aftab?
Alhamdulillah, we have managed all these cases endoscopically, with the recent ones is with minimal complication and with promising results. Previously, like all these procedures were done radically. Like for example, 2-3 दिन का बच्चा है, इस पे हम वीडियो throw incision over the palate and take the hammer and gouge. सही बस patient मुताबिक. Now we are more sophisticated. We are doing all cases endoscopically. So patient with sleep-related breathing disorders are best with using a multidisciplinary approach. Lifestyle changes, appliances, and surgical intervention are all treatment modalities that are available for this patient, and the combination of these treatment options may be required to adequately resolve their problem. Thorough assessment and careful patient selection, particularly for surgical treatment, is essential for a successful outcome. Thank you so much.
Alhamdulillah. Today's session underscored the value of shared knowledge, thoughtful discussions, and collective expertise in addressing one of the complex clinical challenges. Such an approach not only enriches our understanding but also strengthens our ability to deliver comprehensive and patient-centered care.
We are truly grateful to all the speakers and organizing committee, especially our chief organizer, Professor Dr. Iqbal Haider, for providing this platform encouraging meaningful academic exchange. Now I would like to invite our esteemed Patron-in-Chief, Dean KCD, Professor Syed Nasir Shah, to come on the stage and share a few words with us.
First, I must congratulate all of you, KCD, a wonderful team, the KMC Dean and the faculty for the third birthday of this grand CPC. So it's credit goes to you people for the continuous efforts. I must thank the presenters and must appreciate their efforts. I have one point message, and that's the more and more collaboration and communication. Because we are one family, the Khyber family, and when we are connected with each other academically and administratively, so there will be good output and better results. And we will be just like a body. Like if we hear some words, our heartbeat increases. Why? Because there is a close coordination between our hearing system and cardiovascular system. So the departments, there are almost 10 to 12 systems. And the hospital, we are treating those systems like the neurology and the gastroenterology and the cardiology. All these are the systems. And all those systems are in a human body. And in human body, all those systems are well connected and well coordinated, isn't it? So why not in the departments and in the institutions? So just like a human body, if all these departments are well connected and well organized, the results will be wonderful. So this is my key message, that we must coordinate more and more and synchronize more and more. We'll get better results. And if we take any disease, any single disease, everything is multifaceted and multidisciplinary. No disease is treated just in a solo effect. It's coordinated. Every system, every disease is coordinated. So we need more coordination, not only for academics, rather in administration, and we'll get better results. Once again, thank you very much. The KMC team, Dean and his faculty, the presenters, the students and the organizers. So this was my message. I hope that we coordinate more and more. Thank you very much.
Thank you, sir. Now I would humbly request our Honorable Dean, Khyber Medical College, Professor Dr. Mahmood Aurangzeb, to come and deliver the closing remarks.
Assalamu alaikum and very good morning to all of you. A delightful day today in which our two sister institutes are collaborating in our grand round which is held monthly in the academic calendar at Khyber Medical College. And congratulations to all of you, Dr. Iqbal Haider, because you all participated from time to time, and to myself that we are celebrating our third anniversary. All right. Now, regarding the topic today, as always, Dr. Iqbal Haider chooses a very interesting topic which basically epitomizes a multidisciplinary approach. So today the topic was obstructive sleep apnea and its different facets from different specialties. I would like to first of all formally welcome Dean KCD and the Vice Dean of KCD. Like I said, an absolute joy. I hope that we interact at this level much more often. The first speaker was Professor Bashir Rahman. Thank you so much. You're doing wonderful work regarding the mandibular distraction osteogenesis. All right. We really enjoyed you sharing your cases with us. Most interesting. And I think above all, other than treating the physiology, the pathophysiology, it's the self-esteem. You know, those children started looking different. So you're doing a wonderful joy and joyful work. Having said, then we move on to Dr. Roxana, a workhorse of the pulmonary medicine and chest medicine. She's a very integral member. The senior person is sitting here, Sadia Ashraf, who's eminently going to embark on a long program of training in interventional pulmonology. So we are sort of stretching the boundaries as the days go by. Thank you for giving an overall picture of sleep apnea and the different indices that you people now use to this effect. Hassan, thank you. Very challenging your job is. And I was just speaking to the Dean KCD, please put up a demand. Because he's having to deal with such difficult intubations, he needs the necessary gadgetry and repertoire to sort of help him with ease in these cases. Again, he very succinctly presented the different criteria by which you preempt a difficult case or what to expect in terms of outcomes. And Aftab then shared with us, of course, as he highlighted, the gateway to the lower respiratory tract has to go through them. You know, they are the taker the disara. So very nicely presented overall. Now, just to tell you about this grand round, Nasir Shah Sahab, what happened is part of my training was at a hospital called the Royal Postgraduate Institute, Hammersmith. So we used to have a grand round there once a month. And when I joined in, I was asked to be part of a presentation. The topic was Ewing sarcoma. But it was not about, it was not a textbook presentation. It was an unusual case of a Ewing sarcoma. And I was tasked, and you know, I was sweating adrenaline. Because there were such heavy weights, people from, if you've heard about St. Bartholomew Hospital, Guy's Hospital, St. George's Hospital, they used to all come for this grand round. So all these textbook authors and people like that were sitting there, and within a month of having traveled from Pakistan, making a presentation there, but that really helped me in my career progression. The standard of that grand round used to be so elite that you've heard of BMJ, British Medical Journal of Medicine. They used to present the first page of the BMJ used to be the grand round of the Hammersmith Hospital. So the idea is to take the level of this grand round to a point where we can share the grand round with our other colleagues and other institutes in the country. And Sajjad is doing a good job in covering these up. But I don't know whether I should book an appointment with Sadi and Roxana in the coming week, because there's something going wrong in my life constantly. And this has been over the last 2 weeks. Now, what happens is that in Scotland, Scotland is famous for a few things, all right? It's called the Highlands of the British Isles. So if you shoot a grouse, it's like a zarkai. If you shoot a grouse in one day, if you catch a salmon in one day, and you shoot a stag, you barasinga idaho, but the antlers are not pointed, they are stubby. This is possibility, but anyhow, so if you do all three, get the trophy of catching a salmon. Salmon doesn't be the fish. Have any of you had salmon? You know, it's that pinky orangey color. It's very nice, very delicious. And at times when these doctors are going to Europe, I tell them, please get me some smoked salmon. Please try it sometime. It is absolutely delicious. Yeah. So if you catch a salmon and you shoot a stag and you shoot a grouse, it's called a McNab. All right? And then there's a Royal McNab. So I'm going through a McNab, but in a negative manner. I'm to collect some very important documents from Swat, so I go for the weekend for those documents, and I come back to Peshawar having forgotten those documents. Then I am told by the recent conference at PGMI on cancer surgery that we are presenting you a lifetime achievement award. They have to please me also from time to time. So I said fine, but they said that you have to make a 15-minute presentation. Now, because I am probably the senior most surgeon in the public sector today in KP, so having been in the practice of surgery for 30-35 years, I know most of the senior surgeons all over Pakistan, and they know me also. But they were all in attendance, they all came, so I thought it's a great opportunity. They know me as the dean, or previously as a professor. Khalid Gondal has known me since I was a senior registrar. And then being on these various regulatory bodies, PMC and PMVC, but they did not know me professionally as a surgeon. So it was a great opportunity for me to present my pioneering work in cancer surgery. I'm not the pioneer of cancer surgery. These patients came to us not because I was an expert. They came to us because at that time there was nobody else. Let's go back 30 years. I came back from